Evening, guys. I was getting a lot many queries regarding the questions on TMD, myofascial pain syndrome, etc. etc. So that is why I made this presentation for you. We will be discussing a little bit of the anatomy of TMJ. We will be discussing the TMD as well as the clinical features, both the disc displacement with reduction and disc displacement without reduction. And then we are going to answer the questions. Temporomandibular joint is a very important joint from the dentist's point of view. It functions in mastication and in speech. And this joint is of great interest for the general dentist, orthodontist, oral surgeon, prosthodontist, conservative dentistry specialist, as well as for the dental radiologist. TMJ is a gangliomo-arthroidal joint. This term is derived from the term ganglimus, means a hinge joint, which allows just one movement, either to and fro or opening, closing in only one plane. Then comes the arthrodia. It means a joint which can permit a gliding motion of the surfaces. So both type of movements are present in this joint. Temporomandibular joint, it is comprised of mandibular condyle, joint surface of temporal bone, an articular disc, a TMJ capsule. This is basically a ligament which covers the whole joint all around. We call it TMJ capsule. And then temporomandibular joint ligament, also known as lateral ligament. This is mandibular condyle. It is an ovoid process which is on the top of the condylar neck, and it is convex in all the directions. This is the lateral pole, this is the medial pole. It is thicker or it is wider in the lateromedial direction as compared to antero-posteriorly. This is the pterygoid fovea where external pterygoid or the lateral pterygoid muscle is attached. This is temporal bones petrous part. The glenoid fossa is the part of the petrous portion or petrous component of the temporal bone. Here we can see the zygomatic process, the articular tubercle to which the lateral ligament or temporomandibular ligament is attached. This is the preglenoid eminence. This is the glenoid fossa, and this is its lateral border. I'm not going into too much detail of the anatomy of TMJ because we have one complete lecture available on detailed anatomy of TMJ. Just covering the topic so that it will make sense and we would be able to answer the questions. Articular disc is the most important anatomic structure of the TMJ. It is biconcave. Biconcave means that it has a structure like this, biconcave. It is concave on the superior surface as well and concave from the inner surface as well. That is why we call it biconcave. Well, So it is a biconcave fibrocartilaginous structure located between the mandibular condyle and the temporal bone component of the joint. It functions to accommodate a hinging action as well as the gliding action between the temporal and mandibular articular bones. Articular disc is roughly oval, firm, and fibrous plate. The anterior band is 2 mm in thickness. Posterior band is 3 mm in thickness. And the central intermediate zone or intermediate band, it is just 1 mm thick. Then more posteriorly, there is a bilaminar or retrodiscal region. When the mandible is at rest, then the condyle rests in its intermediate zone or intermediate band. It is shaped like a peaked cap that divides the joint into two compartments, the upper compartment and lower compartment. Upper compartment is slightly larger as compared to the lower compartment. Here we can see both the compartments or cavities, the superior synovial cavity and the inferior synovial cavity. These two compartments or these two cavities, they are filled with the synovial fluid. Hinging movements, they take place in the lower compartment, means opening and closure. And the gliding movement, as we can see in this picture, they take place in the upper compartment. The superior surface of the disc, it is saddle shaped so that it can be easily fitted in the cranial contour. And the inferior surface is concave so that condyle can be fitted in it, or it could be fitting over the condyle. This is a schematic diagram over here we can see. This is the temporal bone. This is the articular eminence. We can see that this is the superior cavity, this is the inferior cavity, and this is the disc. This is the condylar head. Well, when we look at these diagrams, it is very difficult for us to actually visualize how this situation is unless we have done the dissection while we were studying anatomy, or if we have assisted certain TMJ operations. So let's see. In this picture, it's a beautiful picture which can give you the idea about the disc, how it looks like actually. This is the anterior band, this is the intermediate band, and this is the posterior band of the disc. This is the disc. And this is the condyle. It is fitted over the condyle. This is lateral pterygoid or external pterygoid muscle. It pierces through the disc in order to gain attachment at the pterygoid fovea. So this area of the disc is quite weak because it is being pierced by the muscle. This is the articular eminence. Well, if we look at the joint antero-posteriorly, something like this will be visible. This is the lateral pole, this is the medial pole, and the disc will be lying on top of the condyle just like it is wearing a cap. Over here we can see that this cap is attached to the condyle with the help of ligaments, and there is a gap between this cap and the condylar surface. Similarly, there is a gap between the temporal bone, articular surface, and the disc. And then capsule is covering all around in order to protect the TMJ as well as to keep the synovial fluid within the cavities. Certain ligaments are also present which assist in movement, which restrict the movement, and which also help in holding the mandible in the joint. There are three functional ligaments and two accessory ligaments. The functional ligaments, they serve as major anatomical component for the joint, like collateral discal ligament, capsular ligament, and temporomandibular ligament. The collateral or discal ligament, it keeps the disc adapted to the condyle. The capsular ligament, I just showed you the capsule which covers the condyle all around. And temporomandibular ligament, it is attached to the it is attached to the articular tubercle of the temporal bone, and then it runs uh, distally or posteriorly to gain attachment to the mandible. Then there are two accessory ligaments. The sphenomandibular ligament is on the medial side of the ramus. It is attached to the lingula. It is medial to the lingula. Lingula is the medial side. There is a projection on the medial side of mandibular foramen. So, sphenomandibular ligament is attached to the lingula and it is on the medial side, whereas stylomandibular ligament is from a styloid process to the posterior border of the mandible or posterior border of the ramus, like this. Here we can see this lateral ligament. As I told you that it is attached to the articular tubercle on the zygomatic process of the temporal bone, and it runs distally posteriorly in order to gain attachment to the condylar neck. This is the joint capsule. This is the sphenomandibular ligament. It is on the medial side of the ramus. Muscles of mastication, they are an integral part of TMJ. There are four pairs of muscles: masseter, temporalis, medial pterygoid, and lateral pterygoid. There are two accessory muscles of mastication, the buccinator and the digastric muscle. When these muscles, they work in a coordinated manner, the chewing action takes place, like this. I'm not going into the detail that what are different movements, the working side and non-working side or balancing side, whatever, because that is beyond the scope of this lecture. So, mandibular movements may occur in multiple axes. And central nervous system, occlusion of the teeth, and temporomandibular joint itself, they all are exerting all the stress on the muscles of mastication. Any problem in all of these, any problem in any of these, I must say, muscles will be affected first, and patient is going to have myofascial pain syndrome. Well, that could be because of other reasons as well, but these are the major causes of causing muscles going into a lot of problem. The movement of mandible during chewing, it is represented by the Posselt's envelope of motion. Teeth, they come in contact only for a very short period of time, from here to here. And if there is no shift of mandible, then this area is not present in the Posselt's envelope, like this. Over here you can see that there is position 1, which is centric relation. This is position 2, which is centric occlusion. But if there is no shift of mandible, there is no interference, then position 1 will be position 2. From centric relation to centric occlusion, there will be closure without any shift. So position 1 will be position 2. We call it centric occluding relationship. Now we are going to discuss temporomandibular joint dysfunction. Because any problem which may occur in the joint, in the occlusion, in the muscles, anatomical, traumatic, or maybe iatrogenic, it will lead to temporomandibular joint dysfunctioning of the joint. In 1983, American Dental Association defined TMD as a group of orofacial disorders characterized by pain in the preauricular area, TMJ or muscles of mastication, limitations or deviations in mandibular range of motion, and clicking sounds or TMJ sounds during the jaw function. TMD pain has been estimated to affect 10% at an average, but in different populations from 5% to 12% range. It is, some of the authors say that it is twice as common in women as compared to in men, whereas other authors they say that it is 3 times more prevalent in women as compared to men. Some of the authors they claim that it is between ages 15 years to 50 years, and other authors they say 20 years to 50 years. Well, whatever the situation is, clinical manifestations of TMD are displacement of the disc. Disc displacement may be with reduction, or disc displacement may be without reduction. In case of disc displacement with reduction, there will be incoordinated movement of the disc and the condyle, and that is why clicking sound is being heard. Otherwise, no other problem will be there, like there is no limitation of the opening, there is no uh, uh, lateral movement is not going to be restricted, etc., etc. Only patient is going to have pain and clicking sound on opening and closure. MRI is the best diagnostic tool for checking the disc of TMJ. CT scan or normal X-rays, they cannot give detail of the disc. So in order to look at the, or in order to make a diagnosis of TMJ dysfunction with or without reduction or whatever the situation is, it is advised to go for an MRI. On an MRI, we can see this is the anterior border, this is the intermediate zone, this is the posterior border, and this is the fibrotic tissue. In this case, there is disc displacement without reduction. When there will be reduction, the clicking sound will be heard. Just giving you hint once again. And there could be clicking sound on the opening. It could be clicking sound on closing, or in both these situations, clicking sound will be heard. Now let's see how clinically both these situations are different. The anterior disc displacement without reduction and anterior disc displacement with reduction. I have taken this picture from Oxen, 5th edition. So anterior disc displacement without reduction, it is also known as closed lock. Anteriorly displaced disc with head of condyle of the disc and trap posterior to it. Patient can rotate, mean rotational movement is there, but cannot translate, means the upper compartment movement is not possible. Lower compartment movement is possible. And there is range of motion is limited. ROM, range of movement or range of motion, it is limited. 25 to 35 millimeter. Patient cannot open more than 35 millimeter. Another hint, just keep this thing in your mind. And without reduction, patient cannot open for more than 35 millimeter. Normal ipsilateral excursive and restricted contralateral excursive means if a patient is having problem on the right side, patient can do right lateral movement but cannot do left lateral movement. This situation could be acute, this situation could be chronic. And when this patient is going to open the mouth, the mandible is going to be deviated towards the affected side. Well, another thing I'm just adding to it, if you will palpate the condylar area in front of the ear, you will feel slight depression on the affected side. Anterior disc displacement with reduction, disc will be in anteromedial position. Periauricular pain caused by the joint movement, may have joint noises, but restriction of movement won't be there. ROM won't be present. Patient can open the mouth easily. Patient may be able to reduce the joint, but it will be difficult if muscles they go into spasm. So over here we can see this is the normal movement, the hinge movement as well as the translational movement is occurring in a normal joint. Over here, disc displacement with reduction. The movement is not coordinated, and that is why clicking sounds they occur. And then disc displacement without reduction. Only hinge movement is possible, translatory movement is restricted, and patient won't be able to open more than 35 millimeter. Over here you can see it is trapped. It is not coming back to its original position. Now we are going to discuss certain questions and we will give the answers on the basis of whatever we have studied. A patient presents with a chief complaint of severe pain in my right ear, right side, which began when eating 3 hours ago. So it is acute. An examination reveals tenderness over the right preauricular region, maximum interincisal opening of 21 millimeter, restriction of movement with deflection towards the right. So right side is affected. Right lateral excursion of 9 millimeter and left lateral excursion is restricted. So patient is having right anterior disc displacement without reduction. A patient with a unilateral left disc displacement without reduction is most likely to present with normal left excursion and limited right excursion. A clinical sign of an acute dislocation without reduction in the right TMJ is deflection of the mandible to the right during protrusion. Reciprocal kick, the reciprocal click while closing is seen in disc displacement with reduction. Clicking sound is one of the signs of disc displacement with reduction. The most likely diagnosis for a patient with an interincisal opening of 30 millimeter before feeling pain, but patient can open 44 millimeter with pain. So there is no displacement of the disc without reduction, and there is no mentioning of clicking sound. So A and B both are ruled out. In trismus, there will be limitation of the opening of mouth. So C is also ruled out. And in subluxation of TMJ, patient is going to have an open bite. So we are left with myofascial pain syndrome. Answer is E. A 23-year-old female complains of bilateral stiffness and soreness in the preauricular region. Her symptoms have been present for the past week and are most pronounced in the morning. The most likely cause is nocturnal bruxism, which is causing muscles to go into spasm. What is the most appropriate management for nocturnal bruxism in the presence of malocclusion? We will give occlusal appliance, then control of parafunctional habits and stress reduction techniques. According to Laskin and Block, they have proposed 4 different phases of therapy for such situations. Phase 1 therapy is psychophysiologic discussion, home therapy, then muscle relaxants and NSAIDs. They say that within 2 to 4 weeks, 50% patients, they are good. What we have discussed in last question, it is phase 2 therapy, home therapy and medications and bite appliance, 2 to 4 weeks. And 20 to 25% of those which are not treated by phase 1, they will be treated by phase 2 therapy. In phase 3, there will be physiotherapy, including ultrasound, electrogalvanic stimulation, etc., etc. And it is all for 4 to 6 weeks. 10 to 15% patients, they will be treated. Rest of the patient, they have to go through the psychological counseling and they have to attend the pain clinics. A patient presents with a dislocated mandible after an accident. After reduction, the management of this patient should be recommend mandibular movement to be minimized. Any dislocation, we have to give the barrel bandage and tell the patient to minimize the movement for a couple of weeks. So over here we are done with this lecture. Probably I was able to clear some problems, some concepts are now clear to you, and hopefully you will take advantage of this lecture. So in case of further queries, you can always send me an inbox message and I will reply. Moreover, some other topics you want to discuss, I am available to make the lectures like this. So see you again with a lecture on some other topic soon. Till then, goodbye. Thank you.